Wait a minute. They don't know who the
I kick it on.
So, now remember, this is all night, so you're gonna have to talk into it.
Have it on this sound room.
No.
I'd like to call to order Board of Managers meeting for March 10th, 2016 at 1:05. I'd like to call Chaplain Dan Baker forward for our invocation.
Let us pray. Dear Lord, thank you for the rain that brings life to the earth, refreshes, brings forth new things that we haven't seen for a while. Let us do the same thing in our own personal lives as we open up our hearts to you and your Spirit, God. And also, would you lead us as those who care for those that are sick and needy in our community to reach out in new ways and make a difference in their lives, just like the spring rain. In your name we pray. Amen.
Amen.
If we could stand for the Pledge of Allegiance. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Wait on that for all.
We have no citizens wishing to address the board. Our next item, item 4 on our agenda, is the approval of minutes of January 29th, 2016 Board Managers Retreat and our February 11th meeting 2016, which is our Board of Managers meeting.
Move approval of our January 29th Board of Managers Retreat minutes and for our February 11th Board of Managers meeting.
Second.
It's been moved by Mr. Bose, second by Charlie Powell. Move approval of our board minutes for January 29, 2016 and February 11th. All in favor?
Aye.
Any opposed? I have no report today, just sad. I thought we might just, I don't know, I don't want to bow our heads, but just sad. This is the last meeting we'll have Dee with us.
She's not dying,
That's what it sounded like.
just retiring.
But when you've been chair and work with Dee, and she, little do anybody knows, Steve and Trent will tell you, you think we've been chair, but Dee has really been the chair. So, okay, our next order is a CEO report. Mr. Early.
Thank you, Mr. Chair. A couple things. Those of you board members that attended our JPS Excellence Award dinner, it was a wonderful evening. And the reason it was a wonderful evening is not only y'all's presence there, which we really appreciate, but the fact that you get to see 12 outstanding people that are great representation of the 6,000 people that run this organization and the care that they give to folks. So those people were the epitome of what we like to hold out as shining examples and mentors for others in our organization. We had a very nice evening, and I want to thank Nikki and the Rewards and Recognition team for doing such a great job of organizing that banquet and having it in such a nice and structured, positive way. And thank you, board members, for attending. We have coming up on March 23rd our service banquet, and this is celebrating service for those who have been with JPS for a period of time that rewards that recognition and merits that recognition. These are people that have put in, and oftentimes over 20 years service to JPS, and we honor those people in their 5, 10, 15, 20, 30, and 40, 50-year type experiences at JPS. We're very honored to have those folks that have seen many changes through JPS's time, and we're honored to have them. So we give opportunity for you as board members to attend that, but more importantly, we give the opportunity for family members, because you know if you spent 25 years at JPS, your family has done some sacrificing as well. So we have them come out and celebrate their time at JPS. I had the luxury of going to the Governance Institute conference, and I really found the conference to be very rewarding. I went to a couple sessions. The two that stood out the best was, and I'll brief staff on it, but I had a wonderful presentation by Dr. Brian Silverstein, who's an MD, who had is one of the national experts on population health, and gave some real guiding principles on some of the keys that you should look at with population health. He was a huge encouragement to the direction we're taking at JPS, and the direction that we have taken, and Mr. Wynn has pointed this out, and that you can go a right direction with population health, and you can go a challenging direction with population health. And I think some of the things that we've put into place, Diana Prachel, Bill Whitman, Wanda, and some of the others have kept JPS at this point in the right direction on population health, and I'm proud of them. But I think there's some key elements that we could learn from. I also met a gentleman by the name of Donald Zeisma, and he really spoke a lot about physician engagement and talked about some of the things that were important. And Dr. Johnson, you might find this interesting. He asked everybody, and it was predominantly made up of physicians in the room, but he asked them how many of them have recently signed up a contract for private practice. And I couldn't tell you how many physicians were in the room, but there were probably 500 people in the room, and not a single hand went up. He then asked the question, how many of you have recently signed up in the last 2 to 3 years with a physician group that is affiliated with a health network or a hospital? 2/3 of the room raised their hands. He then asked the third question and said, in your contracts, describe to me or tell me if you had any level of a performance-based as we move from volume to performance-based. All of those hands raised as well. So that was a pretty interesting trend. Now, one could call that anecdotal, but it was a group of people throughout the nation who didn't represent one cause or one network showing the direction of healthcare. And so I think our physicians are well understanding and cooperative on our efforts to look from a place where we were historically that was volume-based to a place where we are to look at a little bit more of how do we accomplish performance and how are we fair to our physicians and fair to our patients. And so that was a helpful discussion for me, and I appreciated it. We have had the luxury of 2 stories in the Fort Worth Star-Telegram that have highlighted some of our programs, which I am incredibly proud of, and so should you as board members, because you as board members help initiate these programs. One of those programs is our homeless program, and there are not many institutions that have a nurse practitioner that literally goes to the under a bridge and helps those people. And I've been with that team. They're exceptional, and they meet with people and make them feel more comfortable about their healthcare needs, begin to make an assessment underneath that bridge, and then encouraging them to get to one of our clinics. And one of the places that was featured in the article was right under the Allen Street Bridge, which you can see the shadow of JPS, and how we have encouraged those people to allow blood pressure tests and those type things, but then get them into our clinics. And when you start looking at the importance to the taxpayer, that means cost containment, because for everybody that comes into our facility and goes to our emergency room and then is discharged, and unfortunately because of the weather or the conditions or the circumstances come right back to that emergency room, that's expense to the taxpayers that is challenging. If we can begin to stem that tide, get those individuals into a clinic setting where it's more efficient for their health care, we will do far better for the individual patient, which is first and foremost, and far better to the taxpayer. So I was proud of the article, but I was proud of the article to its efforts to educate the community. So I want to thank the Star Telegram for taking the effort to educate the community on a program that we have. And then our Stroke Center and some of the things that we've done with our innovations there. I too want to thank the Star Telegram again for their efforts to educate a community as to the service lines that JPS can provide care to, which again has a big result on our patients and an end result on our taxpayers. The last thing I would like to do, if you will indulge me, Mr. Chair, I've worked with Dee Post for quite a while. The whole time I've been at JPS, Dee has played a role in that. And we as staff appreciate her very much. She handles so many of the situations for us, not only for you as board members, but a lot. We have a great team of administrative assistants back at JPS, and they function very much like a team of 9 players who all play shortstop. And that is when the third baseman runs to cut off the play, the shortstop then fills in at third base. Dee Post is multi-talented and is filled in a variety of ways and has played a role for all of us. And she's put up with me, and that takes a special award. I don't think you need to comment too much on that. It was intended to be rhetorical. No, I'm just kidding. Dee, I think it's important that you chose this meeting to be your last and retire from, because this is the most publicized meeting. It's our first live streaming meeting, so now the whole world will know. And I imagine that your Facebook account and your Twitter account will just explode. But one of the things on behalf of all the staff, and there is going to be a retirement party back, and I know that you board members will play a key part in that. But we as staff wanted to do a couple things for you, this being the first. Dee, we'd like to give you a present from the hearts of all of us. Your colleagues as administrative assistants were instrumental in this. The folks that you have provided service to on the executive staff want to provide this to you. And it's just a thanks that when you wear this, you'll think of us. And it's something to shine and something to remind you of how shining and what a help you were to us on the executive team and to this health network. So Dee, thank you very, very much. The funny thing is, wherever you hug her, you're going to get captured by camera.
I feel like I'm the lucky one.
So, Mr. Chair, that is my report, and whatever questions that you all have or comments that you have. And I would end by saying this, we are proud to be live streaming today. We're proud to call attentions to articles that are in the paper about us so that others might be able to read them or see them. Let the community know about the deliberations. Mr. Keeley, we're happy that you chose to come down here and still continue to be that input for us and that guiding principle that you provide from a citizen standpoint. We're thankful for that. When you agree and when you disagree with us, those are all helpful, and we appreciate that. So that's my report, Mr. Chairman.
Mr. Hurley, I have a couple of questions for you.
Yes, sir.
Okay. First of all, I should have asked, as some individuals I like to say hello to. Could I say hello? No. One is the conference that you attended. Where was that?
It was in Florida.
So did you ride your horse or did you fly?
He didn't fly, I guarantee you. He didn't fly.
Well, I did take a vehicle because I think it's important to see this country. And I think it's important to get to know people. But I realize I'm live streaming, but I do need to tell this story, and I apologize, Mr. Chair. But while I was leaving Florida, it was the night that, and I'll repeat this to our team back at JPS, but it was a night when the tornadoes went through New Orleans, and I'm sorry for the loss of life in New Orleans, and I'm sorry for what happened to the traumatic experience that Florida faced. But as I was driving out of Florida, my phone went off, and it said, "Seek shelter immediately." And my phone went off and said, "If you are near Milton, Florida, seek shelter immediately." And I could hardly see the highway, so I looked up, and the exit sign was Milton, Florida. So the next exit, I pulled off, and it happened to be a rest stop. And so I pulled off, and there were about 50 cars, and there was really only one slot to pull my car in. So I pulled in, and I could see nothing. I knew there was a tree over close to me. And Bill Whitman called me during that time and wanted to go over a few things with me. And Bill said, "What's that noise?" And I said, "I believe I might be in a tornado." And Bill said, "Well, don't talk to me. Just get off the phone." So there was a lightning strike, and next to me in the parking slot was a pole. It had about a 4-foot circumference to it. It was about 30 feet tall. And on top of that pole was the Blue Angels F-16, because I was just outside of Pensacola, Florida, the home to the Blue Angels. And I called Bill back, and I said, "Would you do me a favor? Because this is just too funny." I said, "This plane that is right next to me has an opportunity in this tornado to come crashing on my car." And I said, "At my funeral, would you mention that I was killed by a plane crash because I drove to Florida because I was afraid to fly, and this F-16 landed on my car and killed me?" And Bill said, "I don't want to talk about this." I said, "Bill, that is just flat funny. It is just funny if I died by a plane crash because I wouldn't fly to Florida." Now the whole world knows.
Thank you, Robert. Item 7 on our agenda is school-based clinics. Diane Prachel, and ask Mr. Early to kind of maybe give us a pre on that.
What this is, members, is in our continuation of trying to let you know, when we brought Mr. Pillai in to talk about the service lines from environmental services to nutritional services to textiles, it was really important that you all have a grasp and an understanding of what goes on. We have a limited time with y'all as board members, and we want to utilize that to the highest level and extent that we can. We've asked Diana Prachel to come, like we do all members of the staff, and give you an idea of some of their levels of oversight in what we're doing. We're going to feature in this one for not only you as board members, but again, I'm appreciative of live streaming because I think there are very few people in our community that understand the importance and value of what we do in our school-based clinics and what that means to our schools and what it means to the kids that we serve in that and their siblings. So Diana is going to walk through the process of what we're doing in our program for school-based health care. And I think the insight will be helpful to y'all, and certainly at the end she'll be available for questions.
Thank you, Robert, and thank you for allowing me to come this afternoon and share with you this very rich story of our school-based clinics at JPS. I can tell by Ms. DeVos' smile that you have wonderful memories of where we have come with our school-based clinics, and so it'll be a delight to walk you through that today. When you think about our school districts, I think most of you know that our school districts actually get funded by the number of kids they have sitting in seats every day. And so when children are not in school, one of the primary reasons that they're not in school is because they don't have access to primary health care. There are many other reasons, but it is in one of the top 3, and that really is the premise behind our school-based clinics. When children miss school, they have lower test scores, they're less likely to graduate, their knowledge is diminished, and not only that, when a teacher is constantly trying to catch children up, the other children in the class may be behind as well because the teacher is constantly having to go backwards. And it's important to remember that that when our kids, low-income students, are nearly twice as likely to be absent from primary school, and that gets worse as they continue on through high school. And so our school-based clinics are really about beginning to build good habits in the youngest of our children so that eventually healthcare becomes a more natural part of their lives. And when you think about JPS and our mission overall, certainly it gives us our first opportunity for these families to understand what our brand is and everything that JPS does for our community. So let's see if we can get this going. There we go. So I want to tell you a little bit of how we got started. Actually, in the early 90s, so we've been around for a long, long time, the very first school-based project was between UNT and UT Arlington. JPS served in sort of a support role as we primarily provided labs and imaging for that first school. The primary objective was to increase pediatric immunizations, and for those of you who are as old as I am, you probably remember the Department of State Health Services, or the State Department actually used to come to our school, right, and give us immunizations at the school. We'd line up. There were lots of tears waiting for your shot, but that's the way it happened many years ago. That went away, as you know, but that was the first project in Tarrant County. With the success of that first project, UTA thought, and that project, by the way, was at Northside. Well, UTA thought if we're going to be involved, we actually need a school-based clinic in Arlington. And so therein became the first JPS school-based clinic called Vita Knox. It opened in 1993. It was a teen and tot center, actually, so the focus was on parenting teenagers and their babies. And Beth McLean, who has been with us for 21 years as the leader of those school-based clinics, said that was really a fun clinic, that first clinic to get started. Eastern Hills became our first JPS clinic in the Fort Worth ISD, and eventually UNT, the University of North Texas, gave up on the Northside Clinic and gave it to us. It's now one of ours, appropriately so. But aside from increasing access to primary and behavioral health care, some of our goals with our school-based clinic are really to increase general health knowledge of the communities that we serve, to reduce ER visits and hospitalizations, because certainly when anyone has access to primary care, they're less likely to get to the ED or be hospitalized, to link families to appropriate social services. These families have access to all of our social workers, case management, etc., and to improve academic performance by reducing those missed school days. Generally, the school district will initiate the request for a new clinic. They reach out to JPS. Most of those clinics are sitting near schools where reduced or free lunches are prevalent. Once they initiate the request, we then do our research on what the needs are in that area. Sometimes the school clinics are started with grants from the Department of State Health Services. So the Department of State Health Services will actually allow money to purchase the first equipment and supplies to open those clinics. In 2008, we had a total of 11 clinics. By 2009, we had 15. In 2010, we had 18. We currently have 20 clinics today. We opened our 20th clinic about a year ago, Western Hills and the Fort Worth ISD. When we think about the history of those clinics, Beth was very happy to share her story, but when we opened our Castleberry clinic, we opened that clinic because it was the only school in the nation where 100% of the children were on free or reduced school lunches at the time. When we opened our Everman site, they had an alarmingly high death rate in their population that year. 5 children had died in the previous year from asthma and diabetes, a chronic disease that can be taken care of with access to primary health care. Beth told me the story of how she cried as she listened to the school administrators talk about wanting a clinic there. We have an interlocal model with our school districts today. You see those. They come to the board for approval. JPS provides caregivers and staff, medical supplies. The district provides the site, utilities, housekeeping. All of the caregivers are advanced primary care nurses or mid-level physician's assistants. This gives you an idea of the school districts that we serve, and the number in parentheses is the number of clinics we have in those school districts. The Haltom City Clinic, which is in Birdwell, one of the 2 in Birdwell, also serves as a care site for some of the Fort Worth ISD students. It's one of our, we call it a tri-local agreement, where you see that both school districts sign off on that, and Fort Worth gives money to Haltom City for that clinic. Fort Worth has 6 clinics. With that Haltom City Clinic, they would tell you they have 7, so they claim 7. The majority of our school-based health centers serve as the medical home to many of the children that utilize that clinic, but the clinic also treats the siblings of those students, if they're enrolled in those schools, and the students' children. So we do have teen parents. We treat our children as well. The health cares of each student varies, the health care needs, but we have seen an increase in the need for behavioral health services, as you would imagine, in that population. Each clinic has a panel size of 750 plus patients. Some are more like 1,000 patients. It can take 12 to 18 months once we open a clinic for that panel size to be full and complete, and certainly kids age out and graduate and move into our other clinics. We generally work very closely with the school district and the school nurse, to drive those referrals. Our teams participate in all those back-to-school roundups, health fairs. They attend PTA meetings as necessary. All of those local school practitioners provide lots of ongoing support to the schools in many ways. When we think about stories we can share, we had an 18-month-old baby who came to a clinic just a few months ago, late on a Friday afternoon. We do have walk-in appointments available in our clinic. The baby was very sick. It was late in the afternoon. The nurse practitioner sent the child on to Cook Children's for the ED. That baby had leukemia. It's doing very well now. though, because we caught it as quickly as we could. And so we are more than just a resource. We do a lot of things. Yes, sir? Yeah?
Go back.
Oh, okay.
Is the reason you showed that particular slide with those girls on that wall, is that the reason? Is justifiable to have the clinics, because as soon as they fall, they're going to go into the clinic?
That is very perceptive of you, sir, and we are happy to take care of them if they fall off that wall. This is a map that really shows you the location of all of our school-based clinics, so you have an idea. We do not provide specialty care within the JPS Health Network, but we work closely with both Cook Children's and Dallas Children's to make sure that all of our children have appropriate specialty care services. We don't have any trouble getting our kids into either of those places, and we appreciate that shared coordination of care very much with our kids. We are open to students and their siblings newborn to 22 years old. We do have same-day appointments available. If a clinic is closed for any reason, not all of the clinics are open 5 days a week, some are 4 days a week. But there's always a sister clinic there to take care of the patients who need to be seen, and certainly on the weekends we can see the kids in our clinics that are open. We do provide all of the services, as you see there, certainly the very ordinary services, but we also do treatment management of diabetes and asthma, which is a chronic condition in many of our school-age children today. We are also a part of the Texas Vaccine for Children's program. If you're not familiar with that program, it is a program that makes sure that every child in the state of Texas has free vaccine, and it's free to the district to give those vaccines to those children if they are Medicaid or underinsured or CHIP children. We do have a program to treat obese children, and we have another wonderful story. We had a young lady who came in. We did all of her diagnostic testing. She actually had diabetes and did not know it. It had gone undetected. That young lady is in a weight loss program, and we're managing her diabetes better, and so we're doing actually some wonderful things. She's gone to a JPS nutritionist. She's dieting and exercising regularly. We have lots of stories I could tell you. We are also Title V funded. That's a grant that the state provides for children who do not qualify for Medicaid or CHIP. And you can see when you look at our payer mix that about 8% of our children last year came in with the Title V funding. The majority of the children we see are Medicaid. About 72% of the children we see in school-based clinics are Medicaid children. You're going to look and say, we have Medicare for children. We actually do. For children who have end-stage renal disease, Medicare has been covering those children for many, many years. This is what our revenue looks like. We're about $7.5 million actual compared to 7.7 budgeted. Our expenses run about $3.2 million. This is what our encounters look like. Our encounters have stayed fairly stagnant the last couple of years. Now we hope we are actually, it's because the children are not having to see us as often as we manage their chronic diseases in other ways. But you can see unique patients. Last year we had 17,000 patients, a total of 43,000 visits in the clinics, meaning each patient came to the clinic about 2.5 times average. And when we look at quality, we're tracking several measures for quality this year. MyChart is our patient portal. And the wonderful thing about MyChart, if you're not familiar with it, is if I do a blood work on you today, you actually can get your test results quicker through MyChart than you can a call or a letter from the doctor's office. And for patients with young children, families with young children, MyChart is a wonderful portal for all of our patients. Actually, we had 27% of our families in the last year have activated MyChart, have activated their portal, which is terrific. 11% are using that portal for bilateral communication. So they're actually saying, I need a refill, I need an appointment, I have a question for my physician. That's how we measure that. Some are just taking advantage of getting their test results and their appointment times.
Diana, is that an app for an iPhone or Android?
It does have an app. There is an app available. And I think now Epic is allowing you to brand that individually. For a while, you could just go to MyChart, you had to log into your hospital or your network, and now you're able to brand those a little more individually, more recently. We do track adolescent immunizations, meningococcal, DTaP, TD. 74% of our kids about have had that, which is terrific. And pediatric immunizations, we specifically track diphtheria, tetanus, pertussis, and 3-year-olds. We've got 85% almost who are up to date on those immunizations. So we're doing a great job there. Patient satisfaction in the clinics runs, our top box score is 84.5% for those folks who would recommend coming back to the school-based clinics, which is also very high. Strategic initiatives, we have a disparate project in our school-based clinics. It's a chronic care project. From that, we've initiated many group classes and home visits. So if a child is hospitalized at Cook Children's or Dallas Children's for asthma exacerbation, that child is targeted for a home visit, and our nurse practitioner will go in the home and help evaluate the environment. And many times we find, you may have heard a story, family did not have a vacuum cleaner to clean up the floors. We've provided some of that. It may be that their filters in their air conditioning units are not changed appropriately, and all of that exacerbates asthma. And so our nurse practitioner is able to get in and talk to those families and share some of that. We're working on stakeholder dashboards for all of our school districts so that we can share with them what we're doing, and they can share with us what they're doing. We meet with most of them regularly, but we didn't have a formal way to report metrics. We're doing that now, and really sharing success, really talking more about what we're doing in our school-based clinics. And so this year, for the first time, we brought all the school districts together at JPS for our meeting to really talk about what vision and strategy were going forward and what their needs were, so that we could meet together. And we will continue to do that. We have very capable leadership with Beth McLean, and Kia Jackson is her dyad partner, the director of the school-based clinics. They are a very successful team, doing very well. We did recently approve here at the board meeting our strategic initiative to get all of our school-based clinics recognized as patient-centered medical homes, which, by the way, NCQA does not recognize many school-based clinics because they're closed. They're not open year-round. Ours are open year-round. Except for the major holidays, our clinics are open. In the summers, we close on Fridays at the request of the school districts, but we're open 4 days a week for those 10-hour days. And we always have, even on holidays, Christmas Eve, at least 2 clinics are open in every quadrant so that our families have a place to go. So we'll be able to achieve that certification, we feel certain. Questions from any of you? Yes, sir.
I have one. If a child is hospitalized, as you said, and cooks, when they're dismissed, how do you learn that they were A, in the hospital, B, what medications they might be taking?
So we'll generally get a report from the hospital if the
electronically or
not electronically. For Cook Children's, they're still faxed to us or mailed to us. Dallas Children's is on the same EMR that we're on, Epic, so we get notification as soon as our children are admitted over there, and we can get that record. We continue to work with Cook Children's on a more electronic sharing of information. They do also download for us quarterly their ED visits for our patients so that we can go back and cross-track that, see where our hot spots are, see what our children are being admitted for as well. That's a great question. Yes, sir.
Diana, what is the process for a school or school district to get a school-based clinic?
So they generally will approach us first and ask us if we're interested in sharing a school-based clinic. Now remember, they've already identified a need within that school district, and generally the last couple, they've had grant dollars to help set up their first clinic. So if you haven't been to Western Hills, which was the newest clinic we opened last year, it is absolutely a beautiful clinic. The school-based clinics are generally in what we used to call portables when I was in school, portable buildings outside the parking lot where overflow classes were held. Some are in strip centers close to the school districts, but generally that's what will happen. And if we can make that work and it's appropriate for us to be there, we certainly will be there. I don't think we've declined any requests since this team has been in place.
So it's not necessarily the school that would request that. It's more the school district.
The ISD generally comes to us with the request. Mm-hmm.
The reason I say that, I did know the background of that. It's just that we had an experience, Robert and I had an experience where they have a program in the Morningside area called the Morningside Children's Project, and they actually wanted to see about how they could get a actual neighborhood clinic.
Oh, okay.
And we recommended to look at the school base
As an option.
Mm-hmm. And that worked. So.
Other questions?
Any other questions? Thank you, Diana.
Thank you, Diana.
Dr. Johnson?
Yes, sir. Excuse my voice, I'm getting over a little something here. I do appreciate whoever sat me next to Dr. Lowry.
Anyone have a glass of salt water?
How does Dr. Lowry feel about that?
So we did meet on March 8th. Outside our regular agenda, we had vivid discussions around strategies for ongoing process improvement in clinical documentation and record keeping. We also had some a nice presentation and some recommendations that were passed from our new Director of Pathology and Laboratory Services, Dr. Janet Miles, And those centered around revision of our critical values list and stat test eligibility. Overall, very good meeting.
I have a question for, did you folks make a decision on medical records, the time frame that's,
Yes, sir. Yeah, for outpatient clinical encounters, the discussion centered around, we had medical records had brought to us, the original recommendation was 14 days. We, in our angst for alignment at a previous meeting, had decided, I think we can do better than that. Let's do it in 3 days. The Medical Records Committee assigned a subcommittee that included several different specialties, our revenue cycle folks, our compliance folks, and what they came up with was the Joint Commission or Centers for Medicare and Medicaid require a maximum of 30 days, but whatever standard you set, you have to adhere to. So the discussion centered around rethinking 3 days because, yeah, we want to do better, but if we trim it down to 3 days, our delinquency rate will probably go up, and then we're not going to be doing as much as we need to do from the compliance standpoint. So with that said, the recommendation was made for 14 days, which is still half of the community standard in terms of we looked at all the other hospitals in the community, and the standard was 30 days. The standard we passed at our MedExec was 14 days, so that's where we stand now.
how about inpatient?
Inpatient, I think, is the same for closure of the record. Now, with that said, on both inpatient and outpatient, we made it clear that what we were talking about here was completion and closure of the record. That any documentation necessary for another physician, whether it be a primary care physician reading a consultant note or a consultant reading a consult from a primary care doc, whichever the case should be, there should be enough clinical documentation immediately after the visit so that continuity of care can occur. But all the other elements that surround closing that chart out or closing the encounter out could go up to 14 days.
The reason that I asked is the Performance Metrics Committee for a Claim has identified that as one of the many performance metrics. And we've been awaiting the medical staff decision on how they'd like to proceed. So now we can go forward with at least that one. And I think we will have done all of our work.
Great.
Thank you. Thank you.
Thank you, Dr. Johnson. Next on agenda item 9 is committee reports. First is Finance Committee.
Yes, sir. We had a committee meeting, a very well-run committee meeting on February. If you did say so, I'm laughing when I said it. It's a trend. We have several of those. Very well-run committee meeting on February 25th, and there are several items in our consent agenda for approval. A couple items I wanted to highlight, though. One was, and it's on our consent agenda, is we did get renewal of our Americaid contract, which is a huge deal. It's been worked on for many, many, many months, and it's a testament to Sharon and her team that they got that across the goal line. I congratulate them. There was an item that was presented regarding our connection enrollment. And as you know, I highlight this as often as I can because I think it's so critical to the continuity of care that we deliver. There's a little quirk in the ACA where at the end of the year people roll off and there tends to be a drop. And in 2014-15 we had a significant drop, and the team did a fantastic job of bringing the numbers back up. And we did have a dip at the end of 2015-16, but it was just very slight, and it's phenomenal work. So this team is to be congratulated as well, and I think that Mr. Early's agreed to mow all of their lawns. This is work they continue to add to those numbers. Finally, there was a contract amendment procedure that we have changed, and I may ask council to help me explain it better, but the chairman has agreed to it. We get a lot of amendments to existing contracts under $200,000, and if you sometimes will look at our finance agenda, it's as long as can be. And so what what we've done with the approval of the chairman is institute a policy whereby we post those, so everyone can go look at them. If they have any questions, we can, of course, bring them up and discuss them, but that we don't have to bring them to the committee for approval. And can you explain the parameters more exactly?
Yeah, what we would do is these would be amendments to the contract where the board has already approved the base contract. The amendment itself is less than $200,000. Those would be at the time we have the posting on the finance agenda of a normal contract that will be coming to finance for consideration. Those would be posted and identified as those contracts. If somebody wished for those to be placed on the agenda, then that could be handled with a notice to me immediately, and we could get it on there. I mean, we have a number of amendments like that one he was talking about in the January finance meeting. We had some for $3,000, many for less than $5,000. And the main thing is you are informed about and giving you have a place to go on the portal. Those contracts and those amendments will be posted. If you have a question, you pick up the phone and call staff or myself. This will streamline the process. So unless somebody has objection on that, the chair and I thought this was a good way moving forward of keeping you informed, but at the same time trying to streamline the process.
That's all I have.
Everything's under 200,000.
Say again? Yeah. This would be any amendments under $200,000 to an existing contract that had already been approved by the board.
Yes.
Okay.
Is there a
Can't hear you, DT.
is there a way that we can, if it hits some percentage of that contract, we need to go back because we don't know.
Not a bad idea.
So what would be the plan?
It's a stop loss, whatever you want to call it. If it's hit a certain percentage, that way it brings to our attention. Otherwise, we may skip it, but it could be a huge
Right,
contract that we don't know about.
If we don't know what the base contract is.
But we're capped at 200.
Yeah, the cap would be within Robert Early's authority under the administrative policy.
But in DT's question, I'm going a step further. You're talking about an aggregate. If you had a bunch of 200,
Yeah.
I think that may be more it wasn't covered, Steve.
Well,
Yeah.
I think that's.
if the aggregate, and we'll be monitoring that, if the aggregate of the amendments, in other words, we get to a point where we've got the base contracts approved, and let's say we have 5 amendments, and that 5th amendment kicks the aggregate number of amendments over 200,000, then that's something that I will suggest we bring to the board at that point. Is that okay?
I think it's the aggregate question.
Good point, though.
Quick correction, or for me, back in your report, did you say Americade, Amerigroup?
Amerigroup.
Or Medicaid,
I'm
Amerigroup?
sorry.
Just for clarification?
Amerigroup, yes.
Amerigroup, thank you. Just wanted you to know I was listening. Now can I go back to sleep?
Mr. Chairman, since Dr. Lowry did mention clarification, Mr. Petty to my right here and myself are both former finance chairs, and I had the pleasure of still serving on finance. And I just have to tell you, the Finance Committee is very fortunate to have such excellent leadership, as was pointed out by Mr. Montgomery, the finance chair, as he started this.
Thank you for highlighting that.
Trent, I just want to.
Yeah, we do. We want to make sure you know.
Live streaming will bring out the best in your voice. Okay. Next is our Human Resources Committee.
We did not have a meeting in February. Our next meeting will be Thursday of March the 24th.
Quality.
There, in your packet, there are 3 sets of minutes from November 5th, January 7th, and February 25th that were all approved. We met this month, so there's nothing on the minute side of it. There were 5 reports that were reviewed at the March 3rd meeting, and I don't see. There was a report by Frank Rosinia with Chief Quality Officer report, and then we had what I call an outstanding presentation by a young physician from Parkland, whose name I always butcher, so I always call him just Dr. Rubin. And he's way out on population health, the way he has tied everything together, at least in Dallas County. We had the Claudy-Clabsy report. And since we're new here, that's for catheter-related infections and central line infections. Laura Burnside presented her date on the JPS patient experience report, and Wanda presented the nursing staffing report. We have one item for the board to approve today, and that is the adoption of the compact between Tarrant County Hospital District and the acclaimed physician group. Okay.
Chip, did you go back a step, because I raised this question also. It says adoption of compact, is that correct?
Yes. It's in your,
Right, I just wanted to explain that word, the compact, why was it? Because you would think it would have said contract, but I thought it was typo at first.
I'm gonna bow to it's not really a contract.
Mr. Chairman, this is a document which outlines expectations of both parties, providers, physicians, which are part of the claim, and what we can expect from those physicians in caring for our patients, and in turn, what those physicians can expect from the district in relation to the relationship that we have with those providers to support them in providing care for the patients. This is part of an effort that's been ongoing now for well over a year with a physician engagement committee. Answer your question?
I had a question for Chuck, and it may be a question for someone else, but the central line infection report, it shows the numbers in 2014 that are obviously a whole lot higher, but the subtext says that the criteria changed dramatically. I mean, like by a decimal point, from 1,000 to 100. And then back in 2015, the criteria changed back to what it was in 2013. Is that an industry-wide change in that metric?
Yes, I don't want to speak for Laura, but I believe it's a definitional change industry-wide. It is not us.
Because it made us look like the central line infections were extraordinarily high in 2014, and I knew proportionally they were not.
Right.
But now we're back down to 215, and so that's going to be the metric that's standardized.
That's what we understand, but they can change that definition, but that is universal.
Well, I just want to say that's a great report, and it's great to see those infection numbers dropping the way they have in both those cases. So those are huge issues, and they've always been quality metrics that we've wondered if we were going to be able to move the dial, and it's yet another one where it's moving in the right direction dramatically. So thank you, Chuck, for your leadership there.
The committee would have done a lot better if we'd have had Trudy to present.
Okay, we need a motion on one item on the quality, on the adoption of the compact between Tarrant County Hospital District and the claim physicians group.
I so moved.
Okay.
Second.
Okay, it's been moved by Steve Montgomery and seconded by Dr. Lowry. All in favor?
Aye.
Any opposed, same sign.
That's it.
Okay.
Thank you.
Planning Committee, Trent Petty.
Yes, sir. We had our meeting, and the only action item is in your packet. It's the approval of the lab upgrade. Angie presented that to planning. It was unanimously recommended for board approval. Minutes are also in your packet. The only thing I think the board probably would want to know is that we continue to work through destination metrics question. If you'll remember when that came back to the board the last time, the direction was to take that back to planning, start looking at some of those specific metrics and working through those so that the board's comfortable with the ultimate recommendation is there. It's a big process. It's going to take several meetings to probably get all those lined out, but staff did a great job presenting those alternatives, and we're working through those, and we'll be bringing those back to the board, Mr. Chairman, as time permits. So we only have the one item recommendation on the lab, phase 1 lab upgrade.
Charlie.
Need a motion?
Yes, sir.
I would just say prior to making the motion that I also noted it came in under budget.
Yes, it did.
Which I thought was an excellent job of staff. Anyway, based on that, I'd so move, Mr. Chairman, we approve it.
Second. Been moved by Charlie Powell, second by Chuck Weber. All in favor?
Aye.
Any opposed, at the same sign? Okay, next is our governance committee, and that's me, and we met on February 25th and November 19th. Minutes are in your packet on the board portal. We got a great report from Mr. Skilling's ERM report, and then we had a compliance report given to us by Irma Lee and internal audit by Michelle. And so there's just been informational. Next item, there are no additional items. Item 11, approval of consent agenda.
Second.
It's moved by Dr. Weber and second by Dr. DeVoe. Approval by consent agenda. All in favor?
Aye.
Any opposed, the same sign. Okay. Next, item 12 is our general counsel, Ms. Adams.
I have no report, Mr. Chairman.
You sure?
I'm positive.
You don't want to talk about your vacation or anything? Okay.
I'll pass.
All right. If there be no other items, we now will reconvene in our executive session pursuant to Chapter 551 of the Texas Government Code for the following. be no other business, can I have a motion to adjourn our meeting?
So moved.
I move to adjourn.
Chuck moved, second by Warren.
Although I was more eloquent.
All in favor?
That was the only thing Warren said the entire meeting.
Is that? I'm impressed that you brought up marijuana in 4 to 6 years.
Section.
I got you.
You can't prove that I said
Nope.
that?
We didn't do that.
I didn't even say it in a positive or negative.